All right, good afternoon, everyone. This is it. This is the last budget hearing for our subcommittee. It's also, as always, the biggest budget hearing of our subcommittee. So welcome everyone to HHS or HSS. We are going to hear the Medicaid budget today. As always, we will start with the analyst, then move to the department, and then witnesses that have signed up in advance. I believe we have 4 witnesses signed up in advance. As a reminder to everyone, everything said, typed, or done during the Zoom hearing is public. It's being broadcast on YouTube and available for public information requests. Finally, before we begin, just want to remind everyone, you should have gotten an email. We have 2 bills to vote on after the budget hearing. So amendments should be in your inboxes, and we will pick that up as soon as we are done with the budget. With that, let us begin. We'll start with the Medicaid budget and the analysis by Ann Wagner. Ann, take it away.
Great, thank you very much, Mr. Chairman and members of the committee. So I'll share my screen to walk through the Medicaid budget analysis for this year. Jumping right in on the first page, this allowance provides $12 billion for the Medicaid program in fiscal 23. This is relatively modest growth of 1.8% or $218 million on a total fund basis. But by fund type, general funds show a much more significant increase of just under $650 million or 20%, mostly to backfill one-time federal aid related to the pandemic. Going into the performance analysis section, the first item I'll discuss is healthcare quality measures under the Health Choice Program. Exhibit 1 on page 7 aggregates about 94 HEDIS measures. These are healthcare outcome measures collected by MDH that are used to evaluate each managed care organization. The bars show the percentage of measures above the national mean in calendar 2019, shown in blue, and then in 2020 shown in red. From this chart, you can see that all but one MCO showed worse performance in calendar 2020. Only United Healthcare's performance improved slightly by 2.6%, and while the drops among otherwise high-performing MCOs are much more significant. MDH acknowledged that the COVID-19 pandemic did have an impact on MCO performance, but didn't provide specific reasons for why the large share of measures would have fallen below national averages. Overall, though, Maryland MCOs still reported 62.8% of total measures above the national mean on average across all the MCOs. And so this keeps with historical trends of outperforming other health plans nationally. Moving on to the second item in the performance analysis section, this section relates to the state's efforts to rebalance long-term care services from nursing homes or institutional care to home and community-based services. Those are services in which individuals receive services to help them continue living in their homes or in an assisted living facility in the community. So on this chart, the line shows the share of Medicaid expenditures supporting home and community-based services. You can see that this has gradually increased over the years as additional funding at the federal level became available for rebalancing efforts. But most recently in fiscal 21, you can see that the COVID-19 pandemic greatly accelerated the shift towards home and community-based service spending. This is driven by changes in spending for both the nursing home expenditures, those dropped by just under 10%, and then home and community-based spending increased by almost 26%. And so you can see that these trends are heavily impacted by the pandemic, as the disproportionate impact of COVID on nursing homes has reduced nursing home utilization. Exhibit 3 on page 10 shows that nursing home utilization. You can see that there was a sharp decline among elderly adults shown on this chart for nursing home utilization in fiscal 21. Utilization in fiscal 22 year to date has increased very slightly from that fiscal 21 level, and this might be in part due to individuals now entering a nursing home who may have delayed that service at the height of the pandemic. But you can see that it's still not risen back up to fiscal 2020 levels. Next, I'll move on to the budget discussion. So beginning in fiscal 22, The budget plan includes a $15 million deficiency for an MCO vaccine incentive program. This would help the state address the slight lag in COVID vaccination rates among Medicaid enrollees compared to COVID vaccination rates statewide. It was previously reported in November that about 50% of eligible Medicaid enrollees ages 12 and up had received at least one dose of vaccine, compared to about 72% of all eligible Marylanders at that time. And so the incentive program will work by offering payments per fully vaccinated individual ages 12 and up once MCOs reach certain thresholds that are set by the department. MCOs have the ability to determine how to incentivize vaccination among their members. And so most recently, the MCOs have implemented a gift card program where enrollees ages 12 and up would receive $100 gift cards for being fully vaccinated before the end of March 22, end of this month. And then another item I wanted to highlight is that at the federal level, the American Rescue Plan also requires that Medicaid programs cover vaccine costs and then the federal government is covering these state expenditures with a 100% federal match. So that's another way that vaccination among Medicaid recipients is being covered. And then the analysis lists a couple different strategies for improving vaccination rates among Medicaid enrollees. These were recommended by the National Academy of State Health Policy, and the department is asked to discuss its progress in implementing these strategies aside from the incentive program, and to provide the most recent data on vaccination rates among Medicaid recipients. So then moving on to another section where federal aid is being provided through Medicaid. The state has received a significant amount of federal aid through a 6.2% enhanced federal match that's being applied on qualifying Medicaid expenses throughout the national declaration of a COVID public health emergency. So Exhibit 5 is showing that across MDH, this generated just over $600 million in additional federal funds in fiscal 21, with almost equivalent general fund savings also becoming available to help the state during the pandemic. When the fiscal 22 budget was passed, however, the national public health emergency was set to expire at the end of calendar 21, but has since been extended twice, so that states will now receive the enhanced match through the end of the fiscal year. And so multiple budget adjustments have recognized those additional federal funds. This includes deficiencies that were introduced with the budget plan. And then most recently, the supplemental budget adds about $109 million in federal funds under Medicaid, and then cuts the same amount of general funds to account for the enhanced match continuing through the fourth quarter of fiscal 22. And then another place where Medicaid is receiving enhanced federal matching funds is through a provision in the American Rescue Plan that provides Maryland with 10% enhanced matching funds specifically on home and community-based services. So Maryland is able to receive this enhanced match through starting April 2021 through the end of March 22. And it is required that those funds generated from the 10% enhanced match must be reinvested to enhance and expand home and community-based services. Budget language from last year requires that most of the federal support from this provision be used on a one-time rate increase. For long-term care providers under Medicaid, this amounts to a 5.2% rate increase that took effect November 1st of 2021. So there was an approved budget amendment that adds $78 million to recognize the federal funds that will be generated and claimed on home and community-based services. But then the budget plan also provides a $37.8 million deficiency to account for the expenditures on the 5.2% rate increase. So this would double budget the spending on the rate increase in fiscal 22. So DLS recommends deleting the deficiency appropriation. And then aside from the rate increase, the budget language didn't specify how MDH should use the remaining funds under Medicaid. So the department is still in the process of deciding how to use the remaining funds. The department is asked to clarify the spending plan for this funding by fiscal year and to provide an update on how any remaining funds would be used. And then there's a second DLS recommendation related to home and community-based services here to adopt committee narrative requesting a report on home and community-based service expansion spending. And then the fiscal 23 budget also includes about $12.6 million to expand slots under the Community Options Waiver Program. This was discussed more in depth in the MDH overview earlier this session, so I won't go too far into detail on that, but considering the recent investments in Community Options Waiver and other home and community-based services, DLS also recommends narrative requesting quarterly reports on expenditures and the waiting list or registry under this program. And then the last item related to federal aid during the pandemic relates to recent announcements that MDH is providing funding from the American Rescue Plan Act State Fiscal Relief Fund for $25 million to nursing homes and then $15 million in grants to adult medical daycare facilities. The department has acknowledged that there have been delays in processing invoices and distributing grants in some other programs. So the department is asked to provide an update on how much of the $15 million for adult medical daycare providers has been distributed, and then whether there have been any delays in processing those grants. And then moving on to a short discussion about utilization trends during the pandemic and the budgetary impact of those, specifically related to risk corridor agreements. So generally, the pandemic led to lower overall healthcare utilization in calendar 2020, and this led to MCOs spending less than their capitated payments. There's normally a medical loss ratio requirement that MCOs spend 85% of their capitated payments, but during the pandemic, it was uncertain whether costs to treat COVID would outweigh the payments or surpass the payments, or if the drop in healthcare utilization would create savings to the MCOs. So CMS allowed states to enter risk corridor agreements with the MCOs mid-year. And so that would allow any losses or savings to be shared between the MCOs and the state and federal governments. And then in calendar 2020, what this table is showing is that 5 MCOs reported low enough spending that the state and the MCOs would split some of the overall savings during that year. So this amounts to about $100 million, shown in bold here, in total savings to the state and federal government. So if you split this based on federal and state shares, that's estimated to provide about $35 million or so that would eventually be recouped by the department. And I will note that the budget currently doesn't reflect these savings, but we wanted to highlight that item here. And so these risk corridor agreements are also in effect for calendar 21 and 22. And DLS recommends adopting narrative, requesting a report on these risk corridor settlements. So then continuing the budget discussion, I'll now skip ahead to page 26. So the biggest change in the Medicaid program in fiscal 23 is about $333 million in new spending on provider rate increases. You can see Exhibit 10 on page 26 shows the rate increases by service type. But just to highlight a few, the mandated 4% rate increase is fully funded. The physician evaluation and management rates shown here are raised to 100% of Medicare. When in past years, the goal was about 93%, or the benchmark was to reach 93% of Medicare rates. So that is enhanced this year in fiscal 23. And then there is $19.6 million in discretionary funding for rate increases for dental services. In the past, there have been at least one rate increase that targeted only certain dental services. So MDH is asked to discuss how it plans to distribute that rate increase in particular. And then the large spending growth due to rate increases is partially offset by changes in enrollment and utilization. This is related to the national public health emergency ending, or at least expected to end in fiscal 23. A condition of the state receiving the 6.2% enhanced federal match through the public health emergency was that Medicaid enrollees couldn't be disenrolled, and that annual redeterminations would be paused so that people wouldn't be disenrolled from a program. And so Exhibit 11 on page 27 shows how this led to large monthly increases in Medicaid enrollment. You can see this especially seen in calendar 2020. There were some large increases in Medicaid enrollment, reaching 20,000 in 1 month, shown here. In calendar 21, this has leveled off slightly, although enrollment has still been growing by around 9,000 to 10,000 people each month. And I did want to highlight here that the orange bars show enrollment in the Maryland Children's Health Program. While individuals haven't been completely disenrolled from Medicaid, they have been, or MDH has been moving people between eligibility categories as applicable. And so more recently, there has been movement among children in Medicaid from the lower income categories to MCHIP, which has a higher income threshold. That income threshold's at 300% of the federal poverty guidelines. And so on Exhibit 12, this shows the average monthly Medicaid enrollment. I'll highlight that the DBM forecast that the budget is based on and the DLS estimate both forecast or both expect that enrollment will fall in most categories as redeterminations would start up again, assuming the national public health emergency ends in the last quarter of fiscal 22 as it currently is set to. And I highlighted MCHIP enrollment because that is one area where the DLS forecast actually would expect to see continuing increase in enrollment even after the public health emergency. As household incomes may improve, this might lead to more children shifting into that MCHIP category. There is a short discussion on pages 30 and 31 about how MDH will resume the redetermination process. CMS has provided some guidance to states that allows them to address any backlogs in redetermination over 12 months after the public health emergency ends. And this was just recently updated actually, so that I think late last week, so that states have 12 months to initiate redeterminations, but will have 14 months to complete the process or complete redeterminations. And the department has indicated that it plans to use the full 12 months to go through the redetermination process, but it will expedite redetermination in the first few months for individuals who are more likely to not be eligible for Medicaid, either because they might have aged out of services or they might have reported a change in income or other circumstances over the public health emergency that would make them ineligible. And so considering Medicaid recipients haven't been required to certify their eligibility in more than a year, the department is asked to discuss its plan for outreach so that Medicaid recipients will know that disenrollment is starting back up again after the public health emergency ends. And then DLS is also recommending restricting funds for administration until the department submits a report on the changes in enrollment that result from the redeterminations resuming. And so to sum up the budget discussion, the expected shifts in enrollment and utilization in fiscal 22 should be covered with additional federal funds as you're seeing the public health emergency extended, and that provides more of the enhanced matching funds. And then in fiscal 23, even though there are slight differences between the DLS and DBM forecasts, the differences are not expected to have a meaningful cost impact. And so the budget currently appears sufficient. And so then I'll briefly go over two issues in the analysis. The first, starting on page 33, summarizes some programmatic changes that result from the health choice waiver being renewed as of January 1st of this year. Exhibit 14 shows that there are 3 new programs authorized. This includes a 5-year pilot program called the Emergency Triage, Treat, and Transport Model. This will allow for ambulance care teams to be reimbursed for emergency transport to alternative destinations instead of emergency departments. So this could be urgent care or other alternative destination. And this program will be implemented in Annapolis, Baltimore City, and then Montgomery County. Also under the waiver renewal, Medicaid reimbursement for services and institutions of medical or mental disease or IMDs will now be extended to any adults ages 22 to 64 with a severe mental illness. Before this renewal, only IMD services for individuals with a secondary mental health diagnosis were reimbursed through Medicaid. And then the last program is the Maternal Opioid Misuse Model. This is actually already a federally funded pilot in St. Mary's County, but that will transition to a statewide program. And this program offers case management to pregnant people diagnosed with an opioid use disorder. I won't be going over the other changes in this renewal or waiver renewal, but some programs listed here are expanded. And in fiscal 23, the allowance generally includes funding to expand those programs. So then the final issue relates to the value-based purchasing program. This is part of MDH's quality assurance activities for the Health Choice program. Exhibit 15 on page 37 shows the calendar 2020 performance among the MCOs. So the red bars show the number of MCO healthcare measures recorded in the disincentive range, or that would cause a charge of a penalty. And then the green shows measures in the incentive range that would receive an incentive payment. The way the program works is MCOs receive payments for the measures and incentive and then pay penalties, and the penalties would fund the incentive payments for other MCOs. And so both incentive payments and penalties are capped at 1% of total capitation paid to each MCO across the different outcomes that are looked at. In the event that penalties exceed incentive payments, there is a secondary distribution where the top 4 performing MCOs receive bonuses using the remaining funds. And so you can see that this structure has led to MCOs that didn't report any measures in the incentive range still receiving over $5 million in incentive payments each. And these recent outcomes, and then also there have been changes to federal regulation that now require MCOs to receive actuarially sound rates on an individual basis. And so this causes problems with charging penalties to some MCOs. This has led MDH to sunset the value-based purchasing program and then instead establish the population health incentive program. And that new program would be based on an incentive-only structure. Under that program, the MCOs would be able to receive payments for reaching certain performance targets. And then they would also receive incentive payments based on improvement in certain measures over the prior year. And so the new population health incentive program took effect at the start of calendar 22, but the value-based purchasing program is still included in the MCO agreements in calendar 21. And so MDH is asked to discuss the transition between these two quality assurance programs. So then DLS recommended actions begin on page 40. I'll just highlight items, let's see, item 3 at the bottom of page 41. This is annual pieces of language that restrict funds in the Medicaid budget from being transferred or spent on any other uses. That's also, I believe item 6 on page 43 is the same, but would apply for the Maryland Children's Health Program. Otherwise, I believe I covered all other recommendations in these remarks, so I'll conclude the presentation and I'm happy to answer any questions.
Okay, thank you, Ann. Are there any questions for the analyst? I have a brief one. And Delegate Henson, go ahead.
I am trying to understand the adult dental pilot program a little better. I see that we have in there a rate increase and you have some comments that we should request from the department. Is there any place where we can get information about utilization of the program?
I didn't include any information on that in the report. I'm sure the department would have adult dental pilot information like that that they could provide, but if not, I could also follow up with them on that. But yes, I think that the department should have that information for you and I'm sure could follow up on that program.
Pilot program, do you know offhand if it built into it any sort of metrics that we should be looking at, what makes a successful pilot, or if they report back periodically on that?
I haven't personally come across reports or the specific benchmarks, but I would be happy to look into that. Or again, sorry, if the department would have, reports they can think of specifically on that pilot, but if not, I can also follow up on that.
Thank you. If I get an opportunity to ask the department and they're able to get that information, then we'll certainly take that off of your tab. But thank you, Ann. Thank you, Mr. Chair.
Thank you. I have a quick question, Ann. With regard to the backlog of grant payments, You mentioned specifically the adult medical day, but you referenced some of the other grant payments as well. Do we have a sense of how many outstanding invoices still exist and what the length of time they've been sitting with the department are?
I don't personally have an update on that. I think the department would be better equipped to provide their current status. I think for the 15 million for adult medical daycare, or daycare providers, I don't believe that was ever, I don't think it had the same backlog problems from back in July. This was just announced in December. But I'll let the department provide an answer on how much of that funding has gone out and any kinds of delays they might have faced with that funding in particular. But other than that, I don't personally have an update on the rest of the invoices at this time.
Yeah, unfortunately, I keep asking the department. I get a lot of platitudes about how they're processing invoices at 2x and 4 times the regular speed, but no actual number about how many are still outstanding and how late those invoices are at this point. So I keep asking, so I'm asking everyone I can. Thank you for that, though. Any other questions? Seeing none, let's go ahead and move to the department. We have Secretary Schrader with us, along with his team. I will let you introduce your team and then provide the department's response. Thank you.
Great. Thank you, Mr. Chair and Vice Chair, committee members. I have with me today, and for the record, Dennis Schrader, Secretary of Health. I have Deputy Secretary for Healthcare Financing and Medicaid, Deputy Secretary Steve Hsu. We have our CFO, Emily Brandenburg, our Medicaid Finance Director, Jennifer McElvey, our Deputy Medicaid Director, Trish Roddy, our Budget Director, Nick Napolitano, and Assistant Secretary Yee. I just wanted to make a few brief comments, turn it over to our CFO for some of the responses, and then Deputy Secretary Hsu will give the rest of the response. Just a couple of quick notes. We have information on the dental program. We can get that to Delegate Henson and the analyst, and we'll do that after this hearing. And then Emily Brandenburg has specific data on the invoices to present, which she'll do when she's answering her questions, as well as information about the adult medical day. The only other thing, I want to thank the analyst for a very good report, and we're very appreciative of that. And then lastly, I wanted to mention that we have been very focused since last summer on Medicaid vaccinations to make sure that, as a follow-up, we've been focused for over a year now on equity in general, but we've also specifically, now that we're getting down to very small numbers of people unvaccinated, paying very close attention to the Medicaid population, and we had the managed care organizations focused on this now for several months. We had an incentive program in place. We were so far ahead of the curve that Region 3 from HHS asked us to brief the other states on how we were doing. And we had raised this as a national question with the White House going back to last summer. So we're very pleased about the progress. We're not declaring victory. We still have a lot of work to do. We're working very closely with the NAACP, and they've been very kind to offer their service, and we've been working with them. So Deputy Secretary Hsu will have more information. The only other thing I'll mention is we now have less than 200,000 people in Maryland over the age of 18 that are unvaccinated. Most of the people that are unvaccinated are children, and mostly in the 5 to 11 category. So we're continuing to work on that. and I'll leave it up to Deputy Secretary Shu to respond. So I'm going to turn it over to Ms. Brandenburg for the beginning of the responses to the analyst questions.
Thank you, Secretary. So my responses start concerning the recommendation to delete the proposed fiscal year 2022 deficiencies under Medicaid and MCHIP for the 5.2 HCBS rate increase. And it was suggesting that funds were already appropriated through an approved budget amendment. The department respectfully does not agree with this recommendation. The descriptions for the deficiencies and budget amendments state their purposes for HCBS rate increase. However, there are two related items supported by this funding. The federal funds needed to account for the 10% enhanced match, which is estimated at $78 million. And the additional $37 million reflects the reinvestment from what we earned with the enhanced match. With respect to the quarterly reports on community option waivers and CFC program financial and registry data, for the remainder of this response, Deputy Secretary Shu will provide.
Could I ask before we turn it over to maybe answer the chair's two questions? Let's cover that.
That would be great.
You raised those in the beginning. So.
Thank you. Thank you, Secretary. Currently, we have 750 invoices in the queue within our 30-day requirement to be paid. However, there are 162 incomplete, which require additional information, and we are working with the vendors to get the supporting details we need such that we can process.
AMDC,
if I can break in on that real quick, Ms. Brandenburg, you said you have 700 and how many?
50 that are in the queue as current.
So how many 750 are in the queue as current? How many are in the queue as not current outside of the 30 days?
So there's 162 that require additional supporting details. Those are outside your 30 days that we are going back and forth with the vendors looking for additional supporting information and details such that they're eligible to be processed.
So there are no invoices outside of the 30 days that don't have any supplemental questions that need to be answered.
At this point, we're through our, yes.
Okay. Thank you. Thank you for, go ahead.
I just wanted to touch base on the Adult Day Center as well. We're waiting for those grant applications. When we receive them, we'll process payment. The signed grant applications.
Okay. Thank you very much. I appreciate that. Please go ahead and continue. I was very interested in getting that information.
Thank you, Mr. Chairman. We'll now turn it over to Deputy Secretary Shu for the balance of the responses.
Good afternoon, Mr. Chair, Vice Chair, members of the committee. Nice to be with you this afternoon. Yes, I want to reiterate the Secretary's compliments about Ann Wagner's work. As you know, Mr. Chairman, I've read a lot of these reports, and she does excellent work. The analyst asked that we clarify our spending plans for the 5.2% HCBS rate increase by fiscal year, including the funding levels currently reflected in fiscal 22 working appropriation and the fiscal 23 allowance, and also to provide an update on whether any decisions have been made on the use of the remaining 25% of funds attributable to the HCBS EF-MAP and a timeline by fiscal year for spending those funds. DLS recommended adding some language restricting funds for administrative purposes under my office, the Office of Deputy Secretary for Healthcare Financing, until a report is submitted on those matters. We respectfully do not agree with that recommendation. Our CMS spending plan is public. We update it regularly, and the analyst does have the link to access it. Regarding the 25% of remaining funds, there are three buckets, DDA being the first. The department intends to award provider grants with the remaining 25% reinvestment dollars. That program is in development. In the area of behavioral health, the department has submitted a request to CMS to implement the coverage of peer support specialists, which is really, I think, very welcome for the state of Maryland. For individuals with a substance use disorder, as described in our February 1st, 2022 spending plan update. the estimates to cover this service through March 31st, 2024 will use up all the remaining funds. And then finally, in the area of long-term care, CMS provided feedback to the department recently that it would not be able to use ARPA money to fill home and community-based services slots until all its approved slots have been filled. So MDH is currently approved for 6,348 slots under the Community Options Program. Through December of 2021, 4,456 of those slots were filled, and we are exploring alternative reinvestment options for those funds. Next, the analyst suggested that MDH provide an update on how much of the $15 million in operating grants has been distributed, the status of any delays or processing difficulties slowing the disbursement of funds, and any solutions or strategies that have been implemented to correct invoice processing and grant management issues. And I think Director Brandenburg covered that largely. But as of February 25th, 2022, notice of grant awards were released for the adult medical daycare providers, which will require signature and return to MDH. As soon as we get those contracts back, we will begin processing and dispersing funds. DLS recommended adopting committee narrative that requests a report on MCO risk corridor settlements across calendar 20 and 2021. The department concurs with that recommendation, Mr. Chairman. Next, we were asked to provide an update on how we plan to distribute the dental services rate increase, specifically discussing whether all dental services will receive a rate increase or if the funding will be targeted to certain services. Our response is that we are planning on targeting all covered dental codes in the proposed fee schedule increase. So this would be across the board, Mr. Chairman. And then MDH should discuss current outreach activities and planned outreach activities following the end of the COVID-19 public health emergency to inform Medicaid beneficiaries that redetermination and disenrollment will resume on July 21st, 2022. DLS recommended that the committees add language restricting funds for the purpose of administration until MDH submits quarterly reports with data and status updates related to the redetermination process. This is an area of concern for us. The department, however, respectfully does not agree with this recommendation. At this point, any quarterly reports with data and status updates would be inaccurate, as individuals' conditions may change materially by the end of the federal PHE. Moreover, the requested information, which is on page 40 of the DLS analysis, is not available to the department, nor does there exist a technical mechanism for us to retrieve this information. Maryland has asked CMS to consider national public services announcements helping Americans to understand the upcoming redeterminations. As there is no announced end to the federal COVID-19 PHE, it's difficult to provide accurate information. MDH has been assured that we will receive 60 days notice from the federal government before the end of the PHE. Maryland has been very proactive about staying up to date with the redeterminations and has been performing them internally all along since March 2020. However, as you know, no person has been disenrolled, but we are keeping up with redeterminations. There are many beneficiaries who've never been through redetermination that may need additional communication to help them understand the reasons for the process and the process itself. The state is considering what statewide messaging may be appropriate and when to begin that communication. Lastly, we were asked to discuss the transition between PHIP and VBP, particularly in calendar 2021. The Population Health Incentive Program, or PHIP, is included in the calendar 22 MCO contracts. Calendar 21 is under the old Value-Based Purchasing Program, or VBP. PHIP, the new one, will reward plans for both reaching certain targets and for improvement. It is an incentive-only program, contrary to the old program, which involved both incentives and disincentives, but raised actuarial questions. We're eager to implement PHIP for calendar 22. That concludes my remarks, Mr. Chairman. I'm happy to answer any questions.
Thank you, Mr. Chairman. We stand ready to take questions.
Any questions? We'll start with Delegate Henson.
For the presentation. I wanted to circle back to the question on our adult dental of the pilot program. From my reading of it, it looks like our provider rate increase is discretionary. It certainly seems like it would be welcome just based on what I'm hearing in my district and from other parts of the state. Can you help us understand why the recommendation was made to increase the rate? Are you seeing any specific successes, or do you have any data that indicates that it's not competitive where it is?
Madam Delegate, I'm going to turn this over to Webster Yee, who will address this issue. Go ahead.
Yep, and Delegate Henson, this is Webster Yee from the Maryland Department of Health. To your question, we monitor our reimbursement rates and check them with the comparables in surrounding states. Compared to the surrounding states, Delaware, Virginia, West Virginia, Pennsylvania, and D.C., Maryland has the third highest reimbursement rates. Delaware and D.C. are the highest and second highest. And in terms of the overall Medicaid dental program, we, thanks to a legislative compromise back in 2018, we expanded our adult dental pilot program to cover individuals over 65 and also dual eligibles. And then we also have existing coverage for children and folks in the REM and other emergency dental programs. We also cover dental services for postpartum women. So there's a report that I will forward to you after this briefing with more information about our dental utilization and rates.
If I might add, Delegate Henson, rates have not been increased in many, many years in the dental sector. As I recall, I don't have it right in front of me, but I believe the last rate increase was in 2015, and that was not across the board. It was only for a few selected codes that were most problematic. So this is very overdue.
Like there's not any amount of support for dental services that we could give that would be too great. From what I'm hearing, it's one of the hardest services to get, and certainly during the pandemic there was a disruption, and it sounds like it's great that these rates will be increasing to hopefully get folks back in and make it attractive for our providers. Thank you, Mr. Chair and Mr. Secretary.
Thank you.
Thank you. Delegate Valentino Smith.
Thank you, Mr. Chair. I have three. Hopefully they'll be short. Thank you, Secretary Schrader and Secretary Hsu. Certainly you have worked through, Herculean times with the pandemic and the population that you serve. And I do want to take this last budget briefing to let you know that Assistant Secretary Webster Yee responds usually within minutes of an information request. So I really want to give some admiration towards him. So one of the questions I had in the corridor risk agreements is I really have concern when we talk about it in savings, it's a really good thing that this money got shared between the MCOs, because it really means that there was a significant decrease in utilization because of the pandemic. And it looks like it could be up to $100 million in care that was not given. The $100 million would have normally been spent on care to a very sick and vulnerable population. It's not a reward to anyone. And I see you shaking your head that you may agree. So I just want you don't expect to have risk corridor agreements for 2023 and the population, do you?
No, we don't. Risk corridors are purely a COVID exigency and not something we want to see continue. And it was only with some reluctance that we did it in 22.
Thank you. I appreciate that. I have a lot of reluctance, but yeah, it is for care not being given. The second question I had was with respect to Medicaid. We've been asking for some time on the Joint Committee on Ending Homelessness how we get information to the state and the policymakers on this population and how significant they are, where they exist, and what their experience is. So to the extent that they're registered in the MCOs, do the MCOs keep, or are you able to garner any information with respect to Medicaid recipients and their housing status?
I don't know the answer to that. I do know that at least some counties keep that data and update it regularly to know how many chronically homeless people there are and where they are.
Right, yeah.
Whether that data, I don't know whether that data is accumulated up into a statewide database by the MCOs. I will find out and get back to you. That's a really good question.
Thank you. So my suggestion is that, I know they do a count, we do this homelessness count and kind of depend
Right.
on people going out and counting and whether they find them or not for our data. But it seems to me, since we're spending so much money in Medicaid and health is so related to housing status, that we might try to get some kind of edit somewhere in the system that helps us understand the housing status for those on Medicaid, so that we can contemplate more significant numbers than just the count or the geographic location. So thank you. And then
Thank you.
my third question was with respect to the interfacility ambulance transport for the Medicaid patients. Are you, or do you have information on the, where there are delays or the amount of delays or the amount of days that, we end up spending on hospital care because we can't get the ambulance transports that we need? Or is that information that you have or you can garner somehow in your system?
We can talk to Director Delbridge about that and see what data he maintains.
Could I ask a clarifying question, Delegate? Are you also including our non-emergency medical transport? Because we have a very large program statewide. We spend over $50 million on that annually. Is that your focus, or are you looking at something else? Because we can brief you on both.
Right. Yeah, no. And I think that system's a good system. We've been striving for years to try and keep costs down.
Yeah, right.
In addition to the emergency room. No, this is more when our Medicaid in the hospital and they need a transport.
Okay. Then we should do that.
Yeah.
Okay. All right. Well, thank you. And I guess this is the sign off for the session and for the work that you did. Thank you very much.
Thank you.
Thank you. Ms. Brandenburg, I had a follow-up question on the adult medical day, $15 million grants. Are you waiting for all of the applications to come in before you make the distribution, or are they on a rolling basis?
A rolling basis.
So have any come in at this point? Have you made any of the 15 million distribution?
I would have to confirm with the program manager on that for you. We just released him on the 25th. I'm not sure when we asked to have him back by, but we can get that information for you.
That would be great. Thank you so much. I appreciate it. Any other question for the department? Seeing none, thank you all very much. We're now going to move to testimony. We have 4 witnesses signed up. And I apologize, I did not have the witness list up. I do now. There we go. We'll start with Laura Hale from the American Heart Association.
Good afternoon, everyone. Thank you, the chair and members of the committee. My name is Laura Hale. I'm the Director of Government Relations for the American Heart Association. Really, I'm here to say thank you. Thank you for your work last year in passing a wonderful bill that expanded postpartum Medicaid coverage up to a year postpartum. We know that in that first year postpartum, those who give birth, women are at greater risk for a variety of complications, including preeclampsia and other things that term with heart disease. And so really in the budget for this year, I really thank you all for making sure that there is good funding for this program and for moving forward with this work. So thank you all so much. That's it for me right now.
Thank you. Move to Joe D'Amatos.
Mr. Chair, members of the committee, Joe D'Amatos from the Health Facilities Association of Maryland. It's good to see all of you here. Looking forward to seeing you in person. Thank you so much for all you do. Testifying in support of the budget with some context. You have our testimony in front of you, but I'd like to summarize some points. Just a reminder that the Health Facilities Association of Maryland's been around for 75 years, and contrary to Delegate Young's theory, I've only been here 12 years, not the full 75 years. But we do represent the majority of skilled nursing and rehab centers and quite a few assisted living centers in Maryland. Look, we support the budget, the 4% statutory increase that is in the budget that was put in for the Fight for 15, which we supported, has been absolutely instrumental in skilled nursing and rehab centers continue to fight this pandemic. We are incredibly grateful for the Hogan administration for the earlier $26 million grant that came with ARPA funds at the end of last session, and that the $25 million in grants that were announced in December. If you have questions about that in a minute, I can answer about that. But I want to point out a couple of things that might surprise you. The state of Maryland has actually spent, in terms of base rates to nursing homes, less than they would have had we not had the pandemic. As Ms. Wagner pointed out, generally speaking, payments to nursing homes are down by 10%. But in terms of utilization and federal match, just to sort of put the numbers in perspective really quickly, that is that in 2020, we had about 500,000 fewer days of utilization. And of course, in 2020, we started the enhanced federal match. Maryland was not one of those states that passed on the enhanced federal match in increased base rates to nursing homes. So if you look at calendar 2020, 500,000 days of fewer care, more money, higher match coming in from the federal government, the Maryland state government underfunded for nursing homes $144 million that they would normally have funded. In 2021, because utilization was down for a longer period of time, remember we had to slide into the decline in utilization in 2020 because of the decline in hospitalizations. In 2021, utilization was down by over 700,000 days, which meant $214 million of state dollars not spent, again, because of that mix between utilization and state match. One last point. When you look at Sunrise, Montgomery County, and their limited number of Medicaid days, but they have some, or Delegate Valentino Smith right next door in Genesis, Larkin Chase, or Delegate Henson in Communicate Care South River, or Delegate Maggione, Stella Maris, or Delegate Young, Marquise Meadow Park. When you look at those places, they're about 78% occupied, which means there's about 22,000 Marylanders, most of whom making those facilities their home. People with multiple chronic conditions who would otherwise be receiving care in hospitals. And so we're at a crossroads. Revenue is in the cellar. Costs with PPE, employee testing, infrastructure, security, increased wages, they're through the roof at a time when revenue's in the cellar. So for those reasons, we support the budget, but we continue to work with you and the Hogan administration, because quite frankly, it's not enough. We need more, and it'll take all of us working together.
Thank you. We'll now move to Dan Martin.
Mr. Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland. Thanks for the opportunity to comment today. And it's good to wind down the whole session's budget hearings again. It's been a pleasure working with you. So first, I want to say thank you to Medicaid. I want to thank Governor Hogan for including funding to continue the collaborative care pilot program in Medicaid, which I'm going to talk about in a minute. I want to thank Medicaid for all the work that they're doing and the continuing partnership with the community on a number of positive initiatives. And thanks to Ms. Wagner for her comprehensive analysis. Just a couple of things I wanted to touch on real quickly. Around that collaborative care pilot program, that's been operating for a few years now. And I want to thank the legislature and this committee in particular for your continued support for expanding that model. This really is the best tool that we have to improve the delivery of behavioral health care in primary care settings, which is where most people with mild to moderate mental health needs, your depression, your anxiety, go to get care. And last year, this committee adopted narrative asking for an interim report with initial data and findings to determine whether full-scale implementation is warranted before the pilot ends next year. And that interim report demonstrated what we knew it would. This model improves the delivery of mental health services in primary care settings, period. It noted that the pilot has demonstrated, quote, clinically significant improvement in depression and anxiety symptoms for more than 65% of pilot participants. 19 other state Medicaid programs are reimbursing for the model. In Maryland, commercial carriers and Medicare are reimbursing. But the inability of large healthcare systems to bill Medicaid is really stifling broader expansion efforts. So you do have an opportunity this year to expand the model statewide through passage of House Bill 935, the Behavioral Health System Modernization Act, which I've talked with several of you about, and we would urge you to support that. And one more thing, we would also encourage you to adopt language or narrative directing a review of Maryland's PASSAR program, which is the Pre-Admission Screening and Resident Review Program. This is a program that screens individuals referred for placement in nursing facilities to ensure the appropriateness of those referrals. This is a federal requirement designed to prevent unnecessary hospitalization and institutionalization of older adults. Unfortunately, Maryland's PASSAR program is a little outdated. There are no PASSAR regulations, policies, or procedures. The actual process itself is very antiquated, with state PASSAR specialists using lengthy and burdensome paper processes to screen individuals, even though there are web-based automated alternatives that are available and that have been available for the past decade and blessed by CMS. Maryland's process can take up to 2 weeks to complete, all while the individual is waiting unnecessarily in hospitals or institutional settings. And so we really need to prioritize modernization of this process and encourage you to adopt some language or narrative directing a review of that process. And so thank you very much for all of your work and thanks for the opportunity to comment.
Thank you. And last but not least, Dana Kaufman.
Thank you very much, Chair Resnick, members of the committee. For the record, I'm Dana Kaufman. I'm here on behalf of 3 different organizations: Lifespan, the Maryland Association of Adult Day Services, and the Maryland National Capital Home Care Association. And I'm going to address the 4% in the budget. And I know that I probably sound like a broken record each time I come before you on this. I'm very well aware, but it needs to be said and it needs to be addressed meaningfully. 2018, the state did have legislation that passed that required a study to be done looking at the cost of care versus the cost of reimbursement. And that study came back and it showed, again, that the two were not equal, and that in certain home and community-based programs, that differential was very much extreme. And now, it's 4 years later, and unfortunately, with inflation trending and COVID-19, that differential continues to grow. And the 4% that was put in the budget, which was used to offset minimum wage, has now basically become the increase that we get. But again, it was done to offset the cost of minimum wage. The state has got to start looking at a plan. And I know I've seen provisions put in different bills to really, again, hone into how, as a state fiscally, we are going to start narrowing that gap, because eventually with that gap continuing to increase, you are going to have providers in the Medicaid program simply not be able to continue to be in business. And this will be at a time when we have an aging population and additional individuals going on the Medicaid rolls. So I ask you, basically, like I do all the time, to really take a look and let's figure out how we're going to, in the short term, make sure that in the next fiscal year, these providers can continue to provide the services that they're doing with reasonable reimbursement rates, and how we are going to close that gap in the future. Thank you.
Thank you. 1 second. Does anybody have any questions for any members of this panel? Seeing none, I do. So, Mr. D'Amatos, I want to follow up on a couple of points with you. You mentioned that because of underutilization and then the lack of pass-through from the federal money to enhance rates, about $144 million was left on the table. What happened to that money? Can you tell me?
I don't know. What the calculation that we use is that if you had normal utilization with the enhanced match, given the utilization that we had, that was the amount of money that was not spent, right? So those are the two variables. So in 2020, that was $144 million in calendar 2020. In calendar 2021, that was $214 million. Now, as you know, Medicaid does their cost report audits right about around this time of year. So we actually have the audited results from 2020 to come up with those numbers. We don't have the audited results yet for 2021. The other thing that's interesting about that time was that Maryland requires 3 hours of direct care a day. And throughout the pandemic, we hovered right around 3.8 or 4 hours a day. So at a time when for fee for service, we were getting fewer dollars because there were less people, we actually increased the number of staffing hours while wages were also went up and the use of agency also went up. So it's the perfect storm in terms of the disconnect between costs rising and revenue being down.
So it sounds like we contributed about $350 million to our wonderful surplus that we are working with on the backs of the nursing homes right now. Follow-up question also for you. I know that at some point when we were talking about outstanding invoices, the nursing home community was still short about 25 million in invoiced grants. Has that been paid out, or has that been processed?
Not yet paid out. So there are 225 skilled nursing and rehab centers in Maryland. The payouts exclude state-owned, state-run facilities, although we fought for Charlotte Hall to be included. So you figure that takes it down to 220. We've been working very closely with the department since December on this, and we appreciate their work on it. But I think we've got about 5 grant applications that aren't in yet that we are aware of. So you figure 222, another 5. So that's 117 applications that are in and grants that are signed. And to my knowledge, none of that money has been dispersed yet. I don't know whether the challenge is at MDH or the comptroller's office. I don't know, but we haven't gotten those dollars yet.
All right. And I'm assuming that's been longer than 30 days.
Yeah.
Okay. All right. Any additional questions for any of the members of the panel? Okay. With that, I do want to make one, since I have the department here, not something to address today because it is not a part of the Medicaid budget, but I do want to mention that I will be following up on the status of payments and processes for the MADAP program. I'll be honest with you, I really don't care about community meetings. I care about the program being operational. So I will be in touch with your office to make sure that that is getting back on track as quickly as possible, because it's not like HIV patients in this state can't go without their meds, or can in many cases afford them. So I'll be following up on that soon. With that, that concludes the budget hearing for today. Just a reminder to the committee, we do have 2 bills to vote on, so please stick around. Everyone else, thank you again for all of your work, all of your testimony, and all the time that you put in round the clock, not just during session, but all throughout the year, to make sure that the health of the people of Maryland is foremost on everyone's minds. So thank you all very much. The budget hearing is adjourned, and we will now move to a voting session. Give everybody a minute. All right. Almost everybody is in the group. There we go. Okay, I think everyone's here. Everyone's here. All right. We have two bills to consider. Everyone should have received the amended versions in their email sometime around 12 o'clock today. The first bill is HB 406. It's got a great sponsor, wonderful bill. This is the bill dealing with out-of-home placements for foster kids. As a quick reminder to everyone, I've been dealing with this now for going on 4 years. When there is no placement at a foster home, a group home, or residential treatment facility, we have foster kids being checked into and left at hospitals throughout the state at no cost to the state. 2 years ago, we had legislation sponsored by Delegate Learman that passed the House, went over to the Senate, then we shut down for COVID, and that was that for that bill. I have brought that bill back this year. There was some concern from a number of local DSS offices, associations of social workers, legal entities, others, about the consequences of potentially requiring local DSS offices to go pick up the kid from the local hospitals, and then what do they do with them then if there is no appropriate placement. We have been working, we got everybody together, we've been working on amendments. They're quite substantial to the bill. Essentially what we do now is as follows. Instead of requiring the local DSS offices to pick up the foster kids from the hospitals, we require either the Department of Health or the Department of Human Services, whoever has custody of the kid, to pay the hospitals Medicaid rates for the stay. And what that would do right now, any stays in the hospital that are not deemed medically necessary, Medicaid denies the charges to the hospital. So the kids basically stay there for free. The hospitals eat the cost. And of course, they take up a bed. So we are going to require any non-medically necessary stay at a hospital to be reimbursed directly by the department at Medicaid rates to the hospital. We will also mandate the department to establish as many beds in appropriate settings as necessary to accommodate these children outside of hospitals. We mandate it and we make them legally liable for it in the legislation. We also provide as an amendment a liability waiver to hospitals. At the moment, it is actually against federal law to place foster kids in hospitals outside of medical necessity. So right now, the Department of Human Services and the Department of Health have been violating federal law by allowing these kids to stay. If we allow this to happen, even for payment, it opens up the hospitals to legal liability. So we make them immune from that liability in the statute. We also, trying to remember everything we did in the amendment. June, help me out. What am I missing?
Well, you struck all of the requirements that were placed on the local departments. So struck out of the bill, you struck out the penalty. There was a monetary penalty in the bill as well. And so that's also been struck. And then I think there are a couple of changes, just a couple additions into the membership force. So there would be a social worker that would be added, as well as representatives of the Maryland Psychological Association and the Citizens Review Board for Children. And then just in addition, in terms of the reporting, that they would collect data on other states and how they states.
And we also added the requirement that the governor appoint a coordinator to manage the transition of all of these kids, to make sure that they're being placed as quickly as possible in the available beds and coordinating all the other aspects of it. So that's the legislation. Those are the amendments. I had 25 people from 12 different organizations on a Zoom call trying to come to terms so that everyone would be satisfied with what we are doing. And everyone felt this was the best way forward. It is not ideal by any stretch of the imagination. I want these kids out of hospitals, But at the same time, there was a lot of concern raised that if they did get taken out of hospitals, the alternative would be to put them in hotel rooms or even sleep on the floors of DSS offices. It is my understanding right now, there is a child sleeping on the floor of a DSS office in Dorchester County. So, so this is happening right now. It is my hope that with this legislation, we spur action from the Department of Human Services and the Department of Health to finally resolve this issue that we've been trying to for years. So that is the amendment. I'd like to move the amendment and then we can have a discussion on it if I can have a second.
Second. Chairman, seconding.
All right, motion second, favored and moved and seconded. Is there any discussion about the amendments? All right, Delegate Valentino Smith and Delegate Henson.
Thank you. And I apologize, Mr. Chairman. I was just now reading through the reprint. So two questions that I had, and I heard you say it really quickly, but help me absorb it. How is this going to incentivize the residential treatment centers to build capacity? Or will it, is that your intent? Is there something in here where you're trying?
So there's two things that are in here that I believe will incentivize the department. The first and foremost is the fact that we are mandating they do it in statute and creating a legal liability for them to do it, for failure to do it. The second thing that we are doing is requiring that they actually pay the hospitals for the stay. At the moment, it is free to the departments to house kids at hospitals. It is free to them because once medical necessity is determined to not be there, Medicaid, the Department of Health, Medicaid, denies the hospitals the payment. And so they stay there for free. The hospitals eat the cost. And by actually forcing them to pay, I believe it will also incentivize them to do so, to that as well.
So can they offer higher rates for these children in the residential treatment centers without us doing more? Or do we have to do something about the rates that they'll be able to pay the residential treatment centers?
Yeah, so the rates are a difficult issue. Obviously, we've been trying to deal with the rates issue for a long time. For those of you who are geeks like me, if you know that Spider-Man meme with the three Spider-Men pointing at each other, every time I ask a department about rates, they point, they'll point to a different Spider-Man. And that's part of the problem that we've had. I have been in discussion all weekend with the governor's office about emergency regulations to try and increase rates for this specific population of kids. And they are looking into it, but we can't legislate it because that becomes very difficult afterwards to change those rates once we legislate. We have to do it through regulations, and I need them to do that.
No, I commend you obviously for the work and the years in this. I just have heard the residential treatment providers say they would take some of these kids, but their costs associated with them are so high.
Right.
That even if they had a bed open without the additional payment, they're too vulnerable to losses to take the kid.
So it is my hope.
If you build it, they will come. If you do this, the rates are.
It is my hope that by mandating their requirement to establish facilities appropriate to these kids, the rates will then have to follow.
And then the second question I had was, I don't know what page it is of the rewrite. It says that in addition to the requirements of paragraph 1 of this section, the court may not commit a child for inpatient care and treatment in a psychiatric facility if, and then it says an administrative law judge has made a determination that the child does not require such treatment. But earlier there were decisions, and I may not be reading the rewrite right, that a licensed psychiatrist or a licensed psychologist had to make a determination. I'm just concerned about putting a medical decision about committing a child or not in an administrative law judge's court. Is that something?
I believe that's existing, June. Is that, can you remind us?
Yes, that's actually, that, we didn't change any of that. That's
You're breaking up.
the
Okay, I mean,
2019
it's
bill
showing
that
for me
you
in
guys-
bold and all caps. It's showing for me in bold and all caps, and so that's why I thought it was a new standard. I think it's page 3,
Yeah, let me see here.
starting at line 16. So
Are
it's,
you able to hear me now?
Yes.
Okay, so that actually, it was in the original bill in 2019. We did not actually touch that part of it. But I believe that the administrative law, that would be the process in which I think the management of the case would go through. So it would be an administrative law that would be probably assigned to the case. Does that make sense, Delegate Valentina Smith?
well, I mean, it gives there's an or, so it's either the administrative law judge that the child does not require the treatment, or clinical staff of the facility caring for the child have determined that the child does not meet it, or commitment is sought due to the ability of a local department to find another suitable placement for the child. So I understood the or being the 2 or 3, but I didn't understand just an administrative law judge.
So understand that this is the initial commitment. So normally speaking, when the department brings a child to a hospital initially, right? It's for some medical reason, right? It has to be for, they can't just, it's not like you're dropping somebody off at school, right? You can't just bring somebody to the hospital
Right.
or just because you want to, because you don't have a placement. They have to have some medical reason to show up to the hospital. So usually in one of these cases, the child may have engaged in some sort of an altercation or has had some sort of a mental health breakdown, or some reason something has happened physically that requires hospitalization. So that's an issue of the initial commitment to the hospital, the initial admission to the hospital. What we're trying to do at this point is make sure, so that says that you can't admit to a hospital unless, and then you have those enumerated sections, but then the rest of the bill deals with what happens after the medical need has passed.
Okay, and it does say in H that the court can't commit them without clear and convincing evidence by a licensed psychiatrist or psychologist.
Okay, right.
Within 48 hours. That's why I understood the use of licensed healthcare providers to make the determination, but I didn't understand where it said in addition to that, an administrative law judge could make the decision. Okay.
So it's in addition, it's not, June, you drafted these, so can you explain a little bit what your thinking was in this?
What page are you on, Delegate Valentina Smith?
I think it's page 3. So the first determination for the child is that by clear and convincing evidence, a licensed psychiatrist or licensed psychologist see the child within 48 hours, so the previous 2 days, and that says that the child has a mental disorder, the child needs inpatient medical care or treatment for the protection of the child or others, the child is unable or unwilling to be voluntarily admitted, and there's no less restrictive form. So that's the standard. And that looks like that's current law. If you add it in, provided by a licensed psychiatrist or psychologist.
Right, so that's the original bill.
Right, then there's a new number 2 that starts on line 16. That's all in caps. It says, in addition to the requirements of paragraph 1, the court may not commit a child for inpatient care and treatment in a psychiatric facility if an administrative law judge has, it looks like the administrative law judge can override the licensed psychiatrist or licensed psychologist.
No, that's in addition. Read it again. It says, in addition to the requirements of paragraph 1,
the court may not commit.
you have to do the following.
Right, so they can't commit them even if a licensed psychiatrist and psychologist saw them in 2 days, made one of the determinations.
Right.
Then even if that happened,
right,
that child cannot be admitted if an administrative law judge makes a determination that the child does not require treatment. So it seems like the ALJ can override the healthcare provider. I'm sorry, maybe
No,
I
it's
made.
okay, you're fine. We want to get this right.
Right,
We're
so
not-
I'm worried that an AL, and people, have two feelings about the administrative law judges. Some are good and some people like that as a venue, some people don't.
But I mean, to be fair, some people like all judges and some people,
Right,
one
right.
have feelings about judges one way or the other, also have feelings about psychoanalysts one way or the other.
Right, so that's why it appears here that we're letting an ALJ override one, which we added in. It's not just clear and convincing evidence, it's clear and convincing evidence by a licensed psychiatrist or licensed psychologist that one of those four exists. So that, look, you cannot put this child in unless within 2 days, somebody made one of those determinations. But then it says, in addition, the court may not commit a child if an administrative law judge has made a determination that the child does not require such treatment.
Right, because again, we're talking about hospitals, not residential treatment facilities or group homes. We're talking about hospitals.
Well, it says psychiatric facility, right?
Right, which is usually affiliated with a hospital, but we're talking about the initial into a hospital. We want to make sure that that there is due process to commit someone to a hospital, in addition to having a psychologist or a licensed psychologist or psychiatrist make that determination. There's got to be some due process. There's got to be a legal authority overseeing that process, and not just a medical provider.
Okay, all right.
Okay? That's where the logic there is. We have to have some due process. This is again to prevent the department from simply shoving kids in, getting two psychologists to agree to it, and just shoving kids into a hospital.
Okay, so this is I'm assuming that is it Merv or whatever from the law firm that represents?
Yes, so this language originally came from the from the Office of the Public Defender. And Mr. Mervis.
Okay, thank you. Thank you for the work on this, and thanks for your patience. Having me make sure.
Yep, Delegate Henson.
Thank you, Mr. Chair, for the work on this that's been put into coming up with a solution to an issue that I know has frustrated everybody on the committee, you in particular, for the longest. I wanted to ask a question about the Foster Children Support Fund. I'm trying to follow the thread of how the fund is populated, and I'm seeing on, let's see what page is this, of the reprint on page 6, I believe it is for the bills purposes, between page 6 and 7. And it's talking about revenue distributed to the fund under subsection B3. I'm having just a little bit of trouble in the reprint following what that original source of revenue is.
Looking for B3. Hang on one second. Can you quote me a line number if possible, if there is one?
So B is on line 14, on which looks like page 4.
Oh, there I
And
see.
then-
Okay, wait. Oh, page 4. That's why. All right. All right. So that's all struck. B. Okay, and then 3. Okay, I'm seeing it now. Got it. B3.
I see B picking back up at what was C, but that was struck to reorder the numbering on line 10 on page 5. And then in B, I see a 1 and a 2, but then it moves on to subsection C.
Okay. So the fund starts at H, right? Are we seeing the same thing?
Yes, subsection H is the fund.
The fund. There's a
Yes.
foster fund, the purpose of the
Establishment of
fund.
the fund. And it's a special fund, right?
Special non-lapsing fund that is subject to treasurer shall hold the fund. The fund consists of revenue to be distributed to the fund under subsection, money appropriated. All right, so that's a very good question. June, where does the money come from? Is it just general funds?
It's actually just a special fund. So this is just a sort of typical, like standard, like boilerplate language for the establishment of a special fund that would be managed. And usually it looks like there's not necessarily a specified appropriation for it, but it is a special fund that is created.
Just in
So
case
it
you want to use
consists of,
it.
if you look on lines 23 on page 6 of the reprint, it says that the funds consist of revenue distributed under B3. You're right. So that's actually an incorrect reference because of the changes in the amendment. So it should actually refer back to, I think that's referring back to B3. That fund was established and related to the original 2000 penalty that was established, but that part of the bill was struck. So,
right.
Yes.
I understand.
Established, but it will no longer get a source of funding from that penalty because it was struck in the
Because
amendment.
there's no penalty. So we could fund it at a future date in some way, budget language. We can fund it through a BRFA. We can fund it through, some other way. To be fair, my preference is that we simply pay for this out of general funds, that the Department of Health be allocated money to be able to appropriately, open and staff facilities for these kids. The special fund is there. Again, it doesn't really have to be, frankly, but we can leave it in as a placeholder if necessary to be able to utilize it for some purpose in the future if we would like.
Thank you, Mr. Chair. That makes absolute sense. My second question, if I can, is about page 6, subsection D. The Maryland Department of Health shall provide the beds necessary to meet the number of children requiring admission and services under this section. So I just am trying to understand who ultimately gives the rates, sets them, and encourages new residential treatment centers. And I just want to make sure that I have that correct in my mind. It is MDH and it's not DHS, right?
So it is complicated. Yes, the answer to your question is yes. It is complicated. Something that it is my hope that this task force that's established under the bill can in the future provide some guidance in simplifying this process. Because there is who funds and operates the facilities, MDH, there is who has custody of the children. It could be MDH, it could be DHS, through the local DSS offices. It is very complicated as to, who has custody and responsibility for these kids. The facilities themselves are MDH.
Thank you. I appreciate it.
Okay. Delegate Valentino Smith.
So I had my hand up and down. So what I was trying to understand then, and you just maybe put it back up, was because this is complicated, you have the first task force. So section 2 is going to go into effect right away, which is section 2 is the task force, June. And then you have the report coming in December, and then the task force going away. So I'm thinking that maybe you want to keep your task force longer because it's so complicated and get another report maybe, because I don't know that they're really going to be able to get it done between June and December. And then if I read it right, and then it looks like you lose your task force after the 2023 session. I think that June, is that correct?
It's around until June 30th of 2023. So you would still have time in the 2023 session to extend the task force if needed.
Right. Well, then you might want to get another report from them, because I think you're only getting recommendations in December 31 of 2022. I guess. All right. That's fine. If you looked at it and you think it's enough time, I just wanted to make sure you had the task force and the reports long enough so you don't open up the can of worms again.
Yeah, I think at this point, you're right. You should probably extend it. There's a lot of work to do, and frankly, it's an election year. Nobody's going to want to sit on a desk for it, especially me. But and I know I'm going to be stuck with it. But at this point, I would rather move forward. We can adjust it with an amendment next year if we need to. Okay.
So
All right.
like to move favorable as amended?
So we already have a motion and a second. Are there any other questions? All right, on the amendment, we have a motion and a second. All in favor signify by saying aye.
Aye.
Any opposed? All right, on the bill as amended, is there a motion?
Move
Bill is
favorable as
amended.
amended.
Motion and second. All in, any discussion? All right, all in favor signify by saying aye.
Aye.
Any opposed, raise your hand. All right, bill passes. Thank you very much. Appreciate it. This is a really, really complicated bill. It would not surprise me, frankly, if it got over to the Senate and they made some changes, and we may have to see it again before the end of session. So wouldn't surprise me, wouldn't be offended by it, but I would like to get it moving so that we can get this issue resolved.
Congratulations, Mr. Chairman. You've been working on this for a long time.
Thank you. We're not quite there yet, but I appreciate the sentiment. The next bill is HB 794. This is Delegate Rosenberg's Opioid Restitution Advisory Council. This is a companion to the bill we passed just last week that made changes to the Opioid Restitution Fund. This establishes the advisory council that helps to direct and guide the money as it comes in. I do believe there might be a minor amendment. We're adding a representative of MACO to the group. The logic behind that was because most of the money is going to be distributed to counties. It would be fair to have a representative of the counties on that board. So that's the only amendment.
Mr. Chairman, there's one more change.
Oh, there is another change. So go ahead. Yes.
Just a change in staffing. So instead of the Behavioral Health Administration staffing the council, it would be the Opioid Operational Command Center.
Right. The OOCC.
We still have one of those going?
Yes, we still do, believe it or not. Okay, so those are the two minor changes. If we can get a motion and a second on the amendments.
Mr. Chairman, move the amendments.
Second.
Motion and a second. Is there any discussion about the amendments? Seeing none, all in favor signify by saying aye.
Aye.
Any opposed? All right.
Mr. Chairman, move the bill as amended.
Thank you. Motion, is there a second?
Second.
Motion and a second on the bill as amended. All in favor signify by saying aye.
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 Any opposed? All right, bill passes unanimously. Thank you all very much. That's it, I believe. And obviously, we're still gonna have bill hearings moving forward, but I think we only have one bill hanging out there. I don't know what we're gonna do with it at the moment. But
We're gonna have more. We're gonna have more.
We're probably gonna have more.
Hold tight.
Oh, that's right. Delegate Valentino Smith still has a whole slew of things for us.
Hold tight.
All right, sounds good, everyone. Thank you very much. We're doing very well. I appreciate everybody's work. Sometime soon we'll be doing decisions. Thank you again.